Good morning, everyone. I'd like to thank the organizers for giving me this opportunity to really focus on what has happened during this year. That is the presentation of the overall survival data of adjuvant therapy in EGFR mutated patients. So, you know that lung cancer is the leading cause of cancer deaths, and only 30% of patients are resectable. Already there was the previous session which showed, that early stage is very difficult to pick up in our setting. And you can see that the 5-year global survival in these patients, despite the surgery, is not very encouraging. So stage-wise, if you go, that the survival would be around 45% to 75%, depending on the stage of the disease. Now, what about the EGFR mutations, which are the common oncogenic drivers in non-small cell lung cancer? If you look at the prevalence data across the global situation, you can see that it's more common in the Asian subcontinent as compared to the Western world. And you can see it varies from 10 to 50%, being really common in the Asian subcontinent. But what happens is if these patients are not treated with the appropriate treatment, their survival is worse than those who are EGFR wild type. And we can see that adjuvant therapy in these patients is an unmet need. So what are the testing recommendations as of now in early stage? Apart from PD-L1, as you can see, EGFR mutation testing has become necessary. And as was highlighted in the previous session, that is why tissue becomes important for us to know what is the EGFR status in these patients. And we treat them accordingly. If you look at the current testing and treatment patterns, now this is an important poster which was presented at the ASCO. This is known as the early EGFR study, where between the years 21 and 22, patients were collected who had undergone surgery for early stage lung cancer in the Middle East, Africa and Latin America as well as Asia. And one looked at the prevalence of EGFR as well as what was the pattern of treatment that was offered to these patients. As you can see, the prevalence is around 50%. And out of these patients, the most common mutation is, of course, the exon del 90 and followed by the L858R. So it is seen that there is almost a 51% of patients are EGFR mutated. So how were these patients treated? And you can see that more than 70% of patients were offered only a surgical treatment with no adjuvant therapy, and 46% had some received some sort of adjuvant chemotherapy. So this was the pattern that came out in this poster which was presented at the recently concluded ASCO. So if after initial treatment, you can see that within the recurrence, if you look across all stages, it would be around 50%. So I think we definitely need to improve on our adjuvant strategies if we were to try and improve this overall survival rate. So now you'll see that there have been so many studies, one of them being represented here, that is the Anita study. But what came out from all these studies was that if you looked at the benefit of adjuvant chemotherapy versus no treatment or observation, then chemotherapy actually improved the disease-free survival, and there was a reduction in the risk of recurrence and as far as adjuvant chemotherapy was concerned, but the benefit at 5 years in terms of overall survival was just 5%. So that was the benefit that was accrued with adjuvant chemotherapy. Whereas if you look at the trials which looked at EGFR TKIs in the adjuvant setting, these mainly related to the first generation TKIs, you can see that there were some discordant results. There were various reasons that were stated for this, going right from the study design, the number of patients included, the duration of the therapy, and several other factors. And you can see that there were some which showed no benefit at all to only disease-free survival benefit, but none of them showed overall survival benefit. And also the meta-analysis showed that there was, in terms of the disease-free survival, there was a significant difference with a 48% reduction in the risk of disease recurrence, and also in overall survival it was 0.64 but did not reach a statistical significance. So why these data have not resulted till then in change in practice, but which has changed as of now, and I've already stated all these factors. Now coming to the study which was most important, and that was for the first time we are seeing an overall survival benefit by the addition of adjuvant TKIs in patients of early stage disease post resection who are mutated for the EGFR. So if you look at this trial, it was a double-blind randomized study of patients with stage 1B, 2, 3A with or without adjuvant chemotherapy. This is according to the 7th edition AJCC classification. The WHO performance status was supposed to be 0 to 1, and it was the EGFR exon 19 and L858R without brain metastasis and with a resection which is a margin-free resection, and maximum interval also was stated depending on whether they received adjuvant chemotherapy or not, and they were stratified according to the stage, the type of EGFR mutation and the ethnicity. And these patients 1:1 randomized to 3 years of osimertinib versus no treatment, that is observation alone. Now the primary endpoint of course was the disease-free survival by the investigator assessment in patients with stage 2 and stage 3A. The reason being that the benefit of adjuvant therapies in stage 1, especially stage 1A, which were not included in these studies, but even stage 1B has always been contentious. So the primary endpoint actually included disease-free survival in stage 2 and 3A. The key secondary endpoints were disease-free survival in the overall population, then also the overall survival and the health quality of life. So these were the important secondary endpoints. So if you look at the baseline characteristics, they were well balanced, predominantly female, but as far as the ethnicity was concerned, the performance status, the stage, and the EGFR mutations, whether it be exon 19 deletion or L858R, and the adjuvant chemotherapy, these were well balanced in both the arms. Then if you look at the disease-free survival data, which was presented maybe 2 to 3 years back, where it showed a significant benefit for stage 2 and stage 3A. The hazard ratio that was expected when the trial was designed was 0.7, but actually they hit a target of 0.27. So it was, really startling hazard ratios in this. And also the overall population, the hazard ratios were almost similar. So these were very important disease-free survival data which led to the approval of this drug in the adjuvant setting. Now, if you look at the 4-year disease-free survival, then you can see that the hazard ratios, though may not compare with the initial, but in spite of that, they are very gratifying. So even stage-wise, all the stages show a benefit in terms of disease-free survival. Then, of course, they looked at the types of disease recurrence, and there are interesting factors which come out here. It is seen that those who received osimertinib had disease-free survival events of about 11% versus 46% for the placebo arm. But the location of the recurrences were different. For example, in the osimertinib arm, it was 38% were loco-regional versus 38% were distant and 62% were loco-regional. Whereas it was just the opposite as far as the placebo arm was concerned. Most of them were distant recurrences to the tune of around 61% and very few loco-regional recurrences. Now, the radiotherapy had not been allowed in this study, so maybe that was one of the reasons. Then, if you looked at the site of disease recurrence, as I said, that mainly it was in the lung, the lymph nodes, and the CNS. And the interesting fact was the CNS disease recurrence was much less in the osimertinib arm. It was 6% versus 11% in the placebo arm. And there was again a separate presentation on the benefit in terms of CNS disease-free survival with the use of adjuvant osimertinib. So if you look at the CNS disease-free survival, and as I said, this was also presented, you can see that again the hazard ratio was very important, and there was almost a 51% reduction in the chance of CNS disease for patients who had received osimertinib. And as you know, this is of course related to the very important pharmacokinetics of this drug is its penetration against the blood-brain barrier. So despite that, it has a best penetration into the CNS. So the overall survival, now this is the important thing, as I mentioned before, all the previous studies did not show any overall survival benefit. So this happens to be the first trial of adjuvant TKIs in resected non-small cell lung cancers, which is now showing an overall survival benefit. And as you can see, the hazard ratio for the overall survival benefit in stage 2 and stage 3A disease, which is the secondary endpoint of this study, the hazard ratio is 0.49. So again, a 51% reduction in the risk of death. And the absolute benefit, if you look at the disease-free, the overall survival rates, then the benefit is 12% in stage 2 and stage 3A, as opposed to the 5% which I had mentioned for chemotherapy. So it is a little more than double. Then what about if you see the overall population, because here it includes the stage 1B patients. Now, in spite of that, you can see that the hazard ratio for the use of osimertinib still stands at 0.49, despite the inclusion of patients with 1B. So definitely these patients should also receive adjuvant osimertinib. And also the absolute benefit in these patients is 10%. So whether you look at the whole population or the stage 2, stage 3A, all of them benefit in terms of overall survival. So that's very important. And if you look at the disease stage, then if you look at the overall hazard ratio stage-wise, then again all of them benefit. So irrespective of the stage, the patients do benefit by the inclusion of osimertinib as an adjuvant therapy. If you look at the subgroup analysis, so whenever you see some overall survival benefit, we always look at which are the patients who are likely to benefit from this intervention. And as you can see, irrespective of whatever the factors taken into consideration, all the patients and all the subgroups benefited, irrespective of the race, the stage, the type of EGFR mutation, and the use or the absence of adjuvant chemotherapy. So this is important. Then if you look at the subsequent treatments, then osimertinib had 22% of patients receiving anti-cancer treatment, whereas 54% of the placebo arm did so. And EGFR TKIs were the most common second treatments in these patients. Now, the safety analysis is no different from what data we have with osimertinib. And so the key takeaway points is in order to improve survival, we need to identify lung cancer early, which was also stated in the panel discussion. Never miss the opportunity to do the EGFR testing. and a multidisciplinary tumor. Now, how do we take it forward? Some questions do still remain. One is, what is the optimal duration of this therapy? Are we only actually delaying the recurrences, or are we going to cure these patients? Well, there is a target study which is looking at 5 years of the TKIs. Then there is a study about de-escalation as well, which is that can we do away with chemotherapy in some of these patients. So there is an Australian study which is looking at whether adjuvant therapy, chemotherapy can be done away with in case we use this adjuvant EGFR TKI. This particular data we cannot conclude from this particular study. And also there are certain 14 gene signatures which are being looked at to see whether stage 1 patients really require adjuvant therapy. So I think with this I'd like to conclude, and I'm open to questions. Thank you.